Good morning, everybody. Welcome to today's sessions about PROM standardization for value-based healthcare. My name is Sara Pontoni. I'm one of the program managers for the Value in Health program. Other contributors today are Sally Cox, also from the National Value in Health teams. She's a principal specialist in our National Informatic Service. You may have seen her work yesterday at the heart failure dashboard launch. We also very fortunate to have Gareth Griffith with us today, also from the Informatics Service. He's a data standard manager and has been leading the PROMs data standardization work for us, and we're very grateful for his input and expertise. And also very grateful to Anne Wrightson joining us today. She's the head of information architecture in the Aneurin Bevan University Health Board, which is one of our South East health boards in Wales. So thank you for our contributors, and thank you all of you for joining us today. Next slide, please. Just for context, so we're all on the same page, a reminder of what we're discussing today. So we particularly focusing on the PROMs, patient-reported outcome measures. These are questionnaires that have been developed with clinicians and patients together. They tend to form two categories. One might be looking at a generic quality of life, or they might be looking at a condition, specific condition or treatment. You may have joined the session just before this one where the lymphedema team in Wales described the process of developing a new PROM. Sometimes there's confusion between PROMs and PROMs. The PROMs are the patient experience measures, again, looking very much at the experience of that individual with that one interaction with the clinical team. This is not where we are focusing at the moment. Everything we talked about today is very much looking at the PROMs, so the outcome measure from the patient's point of view. Next slide, please. Again, for context, Wales is small and perfectly formed. We have 7 health boards. They provide a mixture of primary, secondary and tertiary care. When we're looking at PROMs collection, we have electronic PROMs across all of the health boards. And that collection is growing pretty much exponentially. Even through COVID, we've seen growing expansion again. We have a number of different platforms in use, sometimes even within the same health boards, and that plethora of platforms is ever growing. We also have one national PROM platform which was developed by our National Informatics Service, or NWIS, and that has been in use for a number of years now. And at the moment, that is the only platform that allows local and national feed of the data into the data warehouse, as I said, locally within the health boards that are collecting, but also nationally within NWIS. Next slide, please. PROMs collection, as I said, has been we've been working on this for a number of years now in Wales, and we have a national set of PROMs that have been agreed across different pathways. This is the list of pathways that we have available. The way that we've gone around is working with the clinical groups nationally, whether the networks, for example, the cardiac network that was presented yesterday with the cardiac or heart failure dashboard, or the national lymphedema team that was working, showing their work this morning, or Plan Care board around the orthopedic, for example. All of that decision making has been clinically led at national level. And as you say, we're spanning and growing still. Now, even though we do have national agreement for these pathways, that doesn't mean that necessarily this is what we're seeing collected locally. There's still sometimes a disparity between national and local, which is why the data standardization work that we're describing today is so important. Next slide, please. Now, one of the reasons we have some, or there can be conflict in that, is because of the different users and stakeholders for this data. Now, PROMs can be used in a variety of different ways, and if you look at the graphic towards the left-hand side, the pyramid, it could be driven by direct care, and we very much encourage that. So it needs to be meaningful for the patient and the clinical team for their interaction in a clinical environment. But then as you go up that pyramid, you can see how that data, as you start collating with and combining it with other data sets, it offers a plethora of different uses that it could be revolutionizing the whole way in which we do healthcare. But because of the different stakeholders and because of the different uses of the data, there can be conflict, and we were aware of that. Next slide, please. We do have as mentioned before, we have a number of different electronic collection systems within Wales. I would say our experience to date is probably that there isn't a perfect platform that fits everybody's needs. There are many very good platforms out there. They all have challenges and limitations and benefits. We listed there some of the perhaps the issues that we have to encounter. Generally speaking, I would say they tend to be either because of lack of functionality or lack of integration. Again, it's not always about the platform, it's about the architecture that it sits within as well. But some of the main issues that we face in sometimes locally and nationally could be the extraction and manipulation of the data for further use, is the feed into data warehouse, whether that is your local data warehouse or the national data warehouse. We have a number of platforms where perhaps the validation of the patient is not done through a trusted source, for example, an electronic master patient index or a PAS system. And again, the lack of standardization, which is why this work is so important. Now, next up is Sally Cox, and she will describe some of the national products that we're developing as part of the Value in Health theme and why this data is so important to be able to achieve our goals. Thank you.
Thanks, Sarah. Hi, my name's Sally and I lead the Value in Health team, the Value in Health analysis team at NHS Wales Informatics Service. So some of you may have seen some of these slides yesterday with the heart failure launch. Apologies if you have, but I'm just going to run through this more of a concise version. So NHS Wales Informatics Service, then, so we're a national organisation supporting health and care technology throughout Wales. We hold data from numerous sources across Welsh health care, including a range of national databases covering secondary care, births, deaths and child health. So my team, we support the National Value in Health programme using this data collected nationally. So why do we need the Value in Health products? There was a commitment in a Healthier Wales in 2018 to develop value-based healthcare as a way of planning and delivering these services. To achieve this, we need to create a data-driven system and make the data available and accessible to those who need it to support service planning, quality improvement and also direct patient care. To date, we've created visualizations to support this direct care, showing individual PROMs in an individual's trajectory embedded into the patient electronic record. And we've now got 3 outcome data dashboards to support the service planning and quality improvement. Dr. Gareth Collier, a chest physician from Hywel Dda, talked about the lung cancer dashboard, which was our first release. He talked about it earlier this week, yesterday, in fact, and how he uses this dashboard in his daily practice. Yesterday, we launched the heart failure dashboard, as previously said, and on Friday, we'll be launching the knee arthroplasty dashboard at 1 o'clock. So still time to sign up for that if it would be of interest. And all of the sessions so far are available or will be available via our website shortly. Okay. So onto the data required for the data dashboards. So this slide shows a patient's journey through NHS, through the NHS thinking in terms of information collected and the data sets that a patient may interact with along the way. The intention here that we're looking at is to try to support the improvement of outcomes. So to do this, we need to bring together all this available data and provide a whole picture to support the service in identifying variations in care. The digitisation of services and joining up of these local and national systems in recent years has enabled us to access more and more national data sets to provide a more complete picture of the patient's journey and to start to make comparisons nationally. Next slide, please. Thank you. Okay, so this slide shows the same slide as before, but now marked up with NHS Wales data sets that are available nationally and at patient level for data linkage, so that we can start to bring the patient's journey to life. So it does show that we do in fact collect an enormous amount of patient level data nationally here in Wales. However, it must be noted that quality and completeness of this data can vary considerably nationally within some of these data sets, and we rely on our data standards teams to drive the improvement. We also rely on data standards to enable the flow of data between these local and national systems, because in order to share, exchange and understand the data, we must standardise the format as well as the meaning. The lack of standardisation in PROMs data makes this process especially challenging. So data sets are usually collected for specific uses, and sometimes we are trying to utilise them for different purposes, and this can often lead to flawed analysis, and this we must be mindful of. We also have lots of data, but turning this data into the really useful information to drive this improvement is the difficult bit. And for this reason, we need clinical and expert user engagement to sense check the data and provide us with ongoing feedback, so we can make these products useful and to realise the value of putting good quality data in at the start. Next slide, please. So why are we doing this? We need this data in a standardised format to feed the value in health products and to support direct care, service planning and quality improvement. Linked PROM data is pivotal to these products, but to make these meaningful comparisons nationally, we need to make sure that we're firstly collecting the same data in the same way nationally, irrespective of the system used, and that everyone uses pre-agreed national standards so that there is no requirement to map local values to national codes, and so that we know that we are comparing apples with apples. So once this data has been analysed, cleaned and transformed, it can then be presented back to the service in the form of easily accessible, engaging products to support the delivery of value-based healthcare. And it is the information standards within NHS Wales that ensure that this is consistent and there's a coherent approach applied to the end-to-end processing of this healthcare information. Okay, next slide, please. Okay, so this is my final slide. There's some examples of some data visualizations from the value in health products. Access is available to some of these at a high level within NHS Wales, but if more detailed views are required, we do have a process to request access through your health board's Caldecott Guardian or Head of Information. We haven't covered any PROM analysis in this brief overview session, which in itself brings many challenges, but this is covered on a session on Friday by Dr. Rob Palmer, Senior Researcher at CEDA. So if this is of interest, please book on this. So next on to our Data Standards Manager at NWIS, Gareth Griffiths, who will talk you through the legal framework and the data assurance process for the acquisition of data.
Hi, I'm Gareth Griffiths, as Sally says, Data Standards Manager at the NHS Wales Informatics Service. So I'm just going to talk you through the legal framework and the standardisation process, and how we've looked to address some of the challenges that Sally mentioned. So as Dr. Sally Lewis described in her talk yesterday, data quality is really a vital factor in the collection of PROMs data. We need to standardise PROMs data for this comparative analysis and to understand the needs of individual patients. So this can only really be achieved with a more formal and well-defined data flow. So the Welsh Health Circular that you can see on the left-hand side of the slide describes the mandate for the central collection of PROMs and clinical audit data. Now, information governance is an important part of this, and as the NHS Wales Informatics Service is not currently a statutory body, we've had to get agreement from medical directors across NHS Wales organisations, and that's been achieved by an official letter, and that's been issued to medical directors as the Caldecott guardians for their organisations, to describe that process. And we're continuing to work very closely with medical directors at each stage of that process. This will ensure that the data being shared is only done with the agreement of those Caldecott guardians. And in terms of some of the documentation, we do have documentation in place, such as the data sharing agreements to provide assurance over the sharing of data between our organisations. And we also have data protection impact assessments, which provide assurance over the use of that data. Next slide, please. So this slide illustrates the information standards assurance process. When this standards assurance process is followed through to completion, that gives us a sort of level of assurance that the data flow can be established to meet the requirements set out in the Welsh Health Circular. So there's a fair bit to digest on this slide, but essentially we can break the process down into 4 key stages. And at each stage of that process, a submission is made to the Welsh Information Standards Board, or WISB, and we need to gain approval from WISB to progress to the next stage. So if we start on the top left-hand side in the dark blue, this is the requirement stage. So this is where the Welsh Health Circular is issued, and that details the requirements of Welsh Government policy and the national programme. And this is documented as part of a requirement notification, which is submitted to WISB. If we gain approval at that stage, we then move on to the development stage. And at that stage, we would establish a stakeholder group, which work to develop an outline proposal in response to that requirement and an outline development plan. That proposal then and plan is shared with all stakeholders in the form of an impact assessment, and so that gives all stakeholders an opportunity to formally respond to that proposal. We use those responses then to revise the proposal, and we draft a data standards change notice, or DSCN, which essentially describes a specification for the data collection. That DSCN is reviewed by the DSCN subgroup, and if we get approval at that stage, we then move to the final stage in green at the bottom right hand side. This is where the revised DSCN and implementation plan is fed into a final proposal that goes to the Welsh Information Standards Board. If we get approval at that stage, we're all clear to go ahead and issue the DSCN to NHS Wales. And there is a process of review as well, whereby we can revisit the requirements post-implementation to ensure that those requirements are still being met, and if necessary, we can revise some of those requirements and reissue a standard and continue through that loop again. Okay, next slide. So how does this process apply to PROMs? PROMs data is already being collected, and the mandate's already been issued by the Welsh Health Circular. So the challenge now really is to get that data flowing on a national basis. So that the typical route to achieve that for PROMs data is illustrated on this slide. So we initially make a formal request to health boards via that official letter, and we try to get hold of some sample data, which helps us to start that initial development of those dashboards. And we then look to establish a more regular flow to feed the prototype dashboards. And we'll draft a DSCN to describe a more formal flow of that data. And then ultimately, we hope to develop a national solution which will be formalized via the DSCN, and one that is compliant with the specification outlined in that DSCN. Next slide, please. So in terms of the scope, the value-based healthcare program sets out some priorities for development, and some of those Sally mentioned earlier, that we're releasing this week, the knee arthroplasty and heart failure dashboards. And at the moment, we're actively working to establish a flow for the knee surgery dashboard to feed those products. So the first DSCN will describe the flow of data for clinical outcomes from the National Joint Registry. There'll then be a second DSCN that describes the standard data set for the knee PROMs questions and answers. And then a further DSCN will describe the metadata associated with each PROM. The metadata DSCN defines a minimum data set of items attached to every PROM. Next slide. So if we look at that PROMs metadata in a bit more detail, this is additional data attached to every form for PROMs form, in addition to the questions and answers. So this is important for the document indexing and retrieval within the National Clinical Repository where PROMs forms are stored. But also this is vitally important for the linkage and analysis of the data in the National Data Store. So the DSCN describes the standard format, the definitions and the value sets associated with each item. So in the metadata DSCN, we're describing things like the patient details, so the NHS number, date of birth, postcode and gender for a patient. We then describe the document details, which includes the form completion date and the organisation where the PROM originates from. And then there's PROM specific and pathway details such as the treatment specialty, the clinical pathway, the form type and serial numbers associated with that form. Next slide, please. Okay, next slide, please. Could we go back to the last slide, sorry. So if we turn our attention to the PROMs questionnaire themselves, we only use data from validated PROMs. So the questions and answers are already well defined, and the scoring methodology is also defined, but the structure of the coding and formats of the data are not defined. So these are the components that are necessary for the data storage and analysis on a national basis. So in addition to the questions and answers, we need to define the data set structure. So there'll be a separate data set to define the pre-op and post-op questions. It will define the patient assessments, the core and additional questions in terms of a shortened question name, which will sort of define the field name for the data set. There'll be a coded value set associated with each field. So, for example, 0 means severe, 1 means moderate, and so on. And then the data format will also be defined in there. So that gives a sort of formalized data structure to the data. Next slide. So for standardized and centralized PROMs data, we need the validated PROMs questions and answers and a DSCN to describe those. We need the standard metadata, and another DSCN will describe that, and essentially a defined data set. And ultimately, this will define the meaningful and comparable data that we need to feed those value and health products. Next slide. So in terms of next steps then, as we continue through the standards development and assurance process, we have a stakeholder group next week on the 22nd of October to meet with stakeholders to further define the content of those DSCNs. Once we have a proposal that is agreed by that subgroup, we will issue an impact assessment which will evaluate the feasibility and set out the implementation plan and give all stakeholders an opportunity to comment and respond to that. And then we will seek formal ratification from WSB in November and December. And assuming that we gain approval from the boards, we will go ahead and issue the standards for metadata and knee surgery via DSCNs in December. Next slide, please. So common data standards is not quite the end of the story. What we also need is an implementation strategy. And for PROMs, this is particularly important in terms of the interoperability standards that are required to collect that information on a consistent basis. So these standards will define a framework of technical standards to allow the data to flow from those local PROMs applications, from electronic patient records and local data repositories, and into the national data resource. That data then can be used for onward processing through to national registries and the SAIL data bank for further research and audits. Okay, now I'm going to hand over to Anne, who's going to describe those technical standards in a bit more detail. Over to you, Anne.
Thank you. Well, building on what's just been said, and this is a rather complex diagram, but what we have here is a logical model, and that means that we haven't decided finally which system is going to do any of these things, but this is how we think it might work. And this is really, I think it's important to stress that this is a picture emerging out of work in progress discussions. So we're sharing with you what's currently in flight, and this is really indicative of how we reckon it might work. Now, Gal's just gone through with you the data standards, and what that means is that we know what the data items are that are needed for the analysis of the data when it arrives at its destination. And we know quite a lot about the structure of that. We know what needs to be in numbers. We know what needs to be logical, for example, but we don't really know how to get it from A to B. So this is our outline idea about how that would need to work. And I'm going to start at the top right of this diagram, which is showing something a bit more detail from the diagram that Gareth just showed you. And we have a number of patient-facing applications which will be gathering the PROMs content and managing the data that they collect in different ways. We have the blue box, which is just below them, which is, I'm calling it a PROMs collection agent. And what that will do will be again, logically, will be to let the patient-facing applications know what they need to be collecting. So, and this takes us over to the area to the left, which I'll get to in a moment. And then there's always also the question of when does all this need to happen? So we need a PROMs scheduling and workflow resource, which is just up a little and to the left of the collection agent. Now, depending exactly what the structure is for a local health board, and I think there will be some specificity here amongst health boards, we may well have different systems that are playing these different roles. But the point of the standardization is that however it happens, we will know a lot about exactly what information is passing from A to B. We will know exactly what data is being received, and it will all be able to be handled the same to give the nationally consistent data that we've just been hearing about. And that, I think that this top right area is the area that we know least about so far. We'll need to be doing a fair bit of work to sort out exactly how that's going to work. Moving over to the left, we now have a box with a nice red, heavy red border to it. Excuse me. And we've already done a bit of work in working out that this is an area of standardization using a base standard, which is known as HL7 FHIR. And in this gives you a data standard, an interoperability standard, which clothes the data standards that Gareth is working on in a way that they can be exchanged efficiently between applications. That's the purpose of an interoperability standard. And we will be holding a question bank. We'll be holding definitions of the actual forms that the data that these patients fill in, which typically contain more than one segment. For example, it could have the Oxford knee score and it could have a general well-being segment, all in the same package that you then send to the patient. Those responses then come back, and the big fat arrow going down and to the left in the middle is all those responses coming back from the patients. Wherever they've been collected at this point, they should all look the same. So this is the interoperability standard, which is carrying the standardized data into the FHIR environment. And from there, some of the data that's collected may well be reusable for other purposes in the national data resource. So we've got the little arrow going downwards saying we may well be able to extract other patient data into FHIR for reuse from these questionnaires. And then, but most important for PROMs, we then have the blue arrow that goes out to the right saying data output for analytics. And this is how the base data in the standards that Gareth's just been talking about will then find its way into the PROMs data resource, which will be in some form part of the national data resource. And from there, there will be two different kinds of uses principally. One is shown going off to the right, which is for data analytics and visualization, and that's has to do with the dashboards that we've seen in previous slides. And then we've also got clinical data reuse, and we've been designing and implementing a small version of this in an Erin Bevan Health Board. And the clinical data reuse in particular that our clinicians want is a patient level dashboard where we'll be feeding data, say, for example, from the knee or the heart failure PROMs for a particular patient over a period of time, would then emerge in the context of the patient record as a patient-focused dashboard. And I think that's typical of a reuse that a local health board would make of this data alongside all the national uses that we've just been hearing about. Finally, I want to go up to the top left-hand part of the diagram, and that's where we need to be using a terminology resource, ontology, vocabulary, lots of different words around this. But basically, whenever you need to be collecting data in a standardized way, you also need to have standardized value sets, and those are needed to feed both the FHIR environment and the data, the raw data environment. So it would make sense to manage that all together. Again, this is just a logical thing so far that we know that we need to do, and we have some more work to do to find out how that's going to work. Okay, I'll finish there. Thank you.
Thank you. I think we're gonna move on to the Q&A section, and I see there's been a few that has been submitted already. if I start from the first one, and perhaps if I can answer it to begin with, is looking at the licensing element, which perhaps I should have touched on at the beginning. We've been very fortunate, I guess, because we are a national program. We're looking, we have approached all different kind of license holders, and as you can appreciate, each license is slightly different. Some of them are very formal, some of them could be quite informal. Generally speaking, so far we have been able to negotiate, generally speaking, free access because we are a national program. Because we are quite unique in what Wales is trying to do. We've been very lucky. We are trying where possible to move our licensing so that they are national licenses and rather than platform specific licenses. That is not always possible. So we are looking at how we try and manage that, and how do we ensure quality assurance as well, and obviously stay within different licensing. We have a team in CEDA which is absolutely instrumental in helping us with this. And again, anybody that want to know more about perhaps model licensing and how we manage that, perhaps drop us an email and we can look at that in more detail after the session today. Just looking at the question again. Sally, if you wouldn't mind, a question for you. How does the data flow back to the health boards for local analysis? Would you mind describing that for us, please? I think you might need to unmute yourself, sorry.
I do apologise. Right, the PROM data that we have collected nationally currently is provided back in the form of views within the National Data Warehouse for the health board information teams to view and analyse. Yeah, so that's it. I think, Sarah, that's how we provide it back currently.
Absolutely, thank you. There's another question here that I might touch to begin with, which is asking us about PPI, so patient and public involvement. We don't have patient and public involvement in the data standards element itself. We have patient and public involvement, or advocates of patients, should I say, so third sector organisation working with us more in the implementation and decision making before it comes to this stage, in the same way that we don't have clinicians into this piece of work. The standardization work is very much data specialist driven. As I said, the decision making on what we collect and when, that is where we look at clinicians and patients to help us in that, and also the implementation of that data and the use of that data. The standardization, and Gareth, correct me if I'm wrong, is more very much driven by the data analyst and data scientist that we have within the health boards and within the system, and making sure that we have that as tight as possible. Gareth, do you want to add anything to that, please?
No, that's absolutely right, Sarah. We have quite a good pool of specialised data standards experts across NHS Wales now within each of the organisations, and they will form part of that group, but they will also identify those with further expertise in the subject matter within their health boards as well, and so they will also form part of that group in terms of the more clinical aspects and more technical as well.
Thank you. And Gareth, if I may stay with you for a second, there's another question here. Fascinating presentation, so thank you for that. I think it's Rob asking the question. Do you have encoding for stage of treatment, for example, OKS, easily marked as pre and post-op? So I think those are orthopedic pathways, but for cancer and I guess cardiac condition as well, where that schedule is more nuanced. Would you mind describing perhaps how we're going around some of those considerations, please?
Yeah, I mean, we've got a couple of options open to us. We can sort of describe that directly as part of the PROMs metadata. So actually sort of put a stamp into the data to say, you know, this is when it was collected and this is the sort of stage of the pathway that was associated with it. But also we're using other data sources and linking to those other data sources, such as the outpatient activity data sets and the admitted patient care data sets that provide that administrative information to describe the activity. If we link to those data sets, we can essentially identify at which stage of the pathway that patient is on anyway. Yeah, a couple of different approaches there, and that will be refined as we work through that with the stakeholder group.
Thank you, Gareth. And Anne, if I may come to you for this question, please, particularly with your local health board's hat on. What do we need to think about when introducing an electronic platform for PROM collection? Any thoughts on that from our perhaps technical expertise and your local expertise, please?
Well, I think the most important thing here is to regard it as a clinical system acquisition in much the same way as you would do for any other clinical system for a specific purpose. So it needs to have its local benefits and risks and all that sort of thing, and its costs really clearly laid out. And also you need to make sure that the requirements are very well drafted, because one of the things that we've found in Erin Bevan, we've had the privilege of collecting some of the experience and burned fingers, which has led to some of this, to our very strong emphasis across this program now on data standards. And the supplier that we're working with, they were sort of a startup and innovator. They were set on initially because they were creative, innovative. They were doing things that looked good, and nobody at that stage really took a very close eye on the data standards and the interoperability. And I think that's very much a strong lesson learned, that it would be necessary to have those requirements now, and this is what we're now working on, that we will be able to clarify exactly what those requirements are and make them uniform across the piece for new contracts. And apart from that, it's just the usual criteria for buying a system. If you're doing something for patients, then you need to have the usability there, which is a bit different from usability for clinical systems. If within the health board you've got other objectives for this data collection, then you need to make sure that with the combination of the local and national architecture, then all of those can be met as well.
Thank you very much. And that it's quite nicely for me to remind you all guys about future session coming up over the week. We have a session tomorrow which looks at the architecture in Wales, and again, for those of you that perhaps are more interested in seeing how we physically get that data captured and then flown within the system, that might be an interesting one for you. I know Sally's already described or pointed to your attention as well the forthcoming session by Dr. Robert Palmer and Amanda Willacott around the analysis of PROMs, and again that is another session that I think you might find of interest following this one. Again, I'd like to just a couple of thanks first. So thanks to Priya, Alistair, Kathleen and Amanda that has been helping behind the scene for this, and again thank you very much for all our speakers today. I'm very grateful to have you on board and helping us with all of this. And a last reflection, really, PROMs collection is very much a jigsaw, a very complex jigsaw that we're still learning ourselves, and we're very keen to collaborate with everybody in Wales and outside Wales that can help us master this jigsaw. Data standard is one piece, but it's only one piece, and that in itself will not resolve or help us finish the jigsaw, but it's definitely one element that we've learned to appreciate. And with that, I'm going to say goodbye, and apologies for those whose questions we've not reached. We're going to work on them offline and then publish them alongside the recording through the website. So thank you very much and enjoy your day.